going to introduce myself now. It's been a pleasure to attend, listen to the presentation so far, and I hope to be able to add something to them. So I'm a consultant psychiatrist, a general adult consultant psychiatrist. I work currently, before I work in the community team, and now I work in an inpatient unit, general adult, 18 to 65-year-old people in hospital, most of them detained under the Mental Health Act. So involuntarily in hospital. That's my daily job. So that's the plan of the presentation. A very brief mention of history, a bit about empathy, the narrow concept, the core concept, a few words on compassion, the broad concept of empathy, and or as we call it, clinical empathy, or empathy in the clinical context. In psychiatry, some factors that have an impact on the deployment of empathy in clinical settings. Some issues regarding the psychiatric training at the moment. Couple of words about empathic understanding, a la Jaspers, versus a recent conceptual development of epistemic harm, and 10 evidence-based ways to enhance clinical empathy as proved in general medicine, not in psychiatry. Some of the work ahead, and I would like to end with a brief clinical vignette that I invented. It is not referred to any particular patient in particular. So very briefly, things started, before David Hume, as Ivana said this morning. But David Hume talked about, sympathy in a similar way to what now would be considered low-level or affective or emotional empathy or mirroring. Adam Smith talked about sympathy, referring to what now would be considered high-level empathy. Fischer was the first to use the term Einfühlung as a technical term in aesthetics in his doctoral thesis. Lips use Einfühlung to explain both how people experience aesthetics objects and how they come to know other people's mental states. He translated Hume's works into German and directed dissertations on Hume. So probably his ideas were very influenced by Hume. Titchener, using a transliteration of the work Empathaia, the Greek word, to translate Einfühlung, introduced the term empathy in 1909. Max Scheler, also a German philosopher, published a book on the nature of sympathy. It's also related to the topic we are discussing. But I wanted to mention this Stein, who was mentioned this morning as well, her dissertation on the problem of empathy. And I mention her. When I mention her, I always mention that she died Sister Teresa Benedicta of the Cross, Discalced Carmelite nun, who died murdered in the gas chambers of Auschwitz II in Birkenau, and she was subsequently canonized as a martyr and saint of the Catholic Church. So in history, the next is important also to mention, to think about when did concern for patients' well-being start, because we've been discussing all these terrible things that happened in the past, some of them still taking place today. So when the well-being of patients started to be significant, an Italian psychiatrist, Vincenzo Cariucci, who was the director of Santa Dorotea Hospital in Florence, stopped the use of chains as a means of restraint for psychiatric patients. William Tuke in York founded a retreat, and there the philosophy was to provide care focused on general health, good food, warm baths, and malt-based drinks. and emphasizing that care and personal support toward the person would succeed. They were Quakers, and they started a significant change in psychiatric practice. Philippe Pinel, also in France, promoted a strict non-violent, non-medical management of mental patients that came to be called the moral treatment, which should be translated as psychological treatment as opposed to physical treatment. In America, Dorothea Dix was an educator, social reformer, and humanitarian whose devotion to the welfare of the mentally ill led to widespread reforms in the United States and abroad. She visited London, Rome. She had an interview with the Pope, and she got the Pope to visit different asylums in Italy. And obviously, importantly, John Connolly in the Hanwell Asylum in Middlesex, where he developed the non-restraint system, where basically the philosophy was that, not to restrain patients physically, which at the time was very sort of a revolution in mental health care. Subsequently reverted, the restraint reappeared and was found to be more effective. So, and there we are, 200 years later or 150 years later, still debating whether that's the case or not. And when did patients' inner experience started to matter in psychiatry? According to Berrios, German Berrios, the incorporation of the subjective experiences into the symptom repertoire of descriptive psychopathology is perhaps the single most important contribution of the 19th century. Before that, descriptions of insanity, and you can read them, were based basically on observation of behavior and psychosocial competence. And during the early 19th century, and particularly in France, changes in psychological theory made it possible for the first time to accept the validity and the relevance of the inner experience, the contents of consciousness of patients. So the narrow concept, very briefly, as we've been discussing this morning, I say narrow concept, the core idea of empathy is affective matching, taking the patients, the person, the target's perspective, and always maintaining clear self-other differentiation. That's the core narrow concept of empathy. A couple of words about compassion, according to Bloom, in his book Against Empathy. He says that it's important to distinguish compassion from empathy. Basically, compassion is always necessary in a helping relationship, in a caring relationship. Empathy is neutral, morally speaking. Narrow empathy is neutral, in terms of morality, and it can have some negative effects. Sometimes you can be empathetic to exploit someone. I always think that people who, for example, people who are torturing other individuals, the good torturers probably are very empathetic. They are able to read people very well, but their objectives are obviously not to help the victim of their actions. So for Bloom, empathy is not essential. Empathy in the narrow sense is not essential for supporting human encounters, helping human encounters. So then we move to the broad concept of empathy, which includes the narrow one, plus other things, plus compassion, plus communication skills, etc. And as we use it in clinical empathy. So now, from now onwards, I'm talking about clinical empathy, or empathy in a clinical context, in particular in psychiatry. And this broader definition seeks to have face validity for clinicians, patients, and the wider public, and is defined as attempting, as far as possible. That's an important consideration. There is a limit, we cannot, I don't know whether you follow Star Trek. We're not Spock, who can do that and read mind of other people, we don't do that. As far as possible, to understand another person's situation, feelings, and perspective, recognizing the difficulties in putting oneself in another's shoes. communicating that understanding, checking its accuracy, and acting on that understanding in a helpful way. So the communicative component is necessary to ascertain whether the empathizer's understanding is correct and to respond to that new knowledge in an appropriate manner. So this definition, as I said earlier, includes communication skill, communication of compassion, optimism, and promotion of autonomy, as reflected in the CARE instrument developed by Professor Merson in Scotland, in Edinburgh. So basically, the broad concept of empathy or clinical empathy includes communication skills, compassion, sympathy, and empathy, the narrow concept, which is, I accept that it is conceptually and not very precise, conceptually speaking, but in terms of the work that clinicians do on a daily basis, is very relevant. And these are the 10, well, this instrument has been translated to different 40 languages. It's used in a variety of contexts: research, education, healthcare, audit, quality improvement, revalidation of doctors. And the questions are 10 questions. You know, was your practitioner, you just seen, making you feel at ease, letting you tell your story, really listening, interested in you as a whole person, being positive, showing care and compassion, explaining things clearly, helping you to take control, making a plan of action with you. All things that patients, or service users, or clients, whatever you want to call them, value a lot. So what about clinical empathy in psychiatry? A study of patients' views on what is good psychiatric care found that the quality of the therapeutic encounter with staff and the feeling of being understood by staff were the most important aspects. The perception of staff allocating time to the patient was also important. Another study found that for psychiatrists, empathy is an important component of the therapeutic alliance. And do patients and psychiatrists agree on which psychiatrists are perceived as empathetic by their respective patients? And this is interesting because this is the only reference I found is this study in 2007 done by a resident in psychiatry, not a research project, big one. And the findings, I think they urgently need to be repeated. We need to repeat the study in a bigger scale. The finding was that there was no correlation found between psychiatrists' self-perception of empathy and patient perceptions of their psychiatrist's empathy. The second one was psychiatrist self-assessed empathy was significantly higher than the patient's ratings of the psychiatrist's empathy. And this difference reached statistical significance when the psychiatrist was male and the patient was female. Okay, I think that's telling us a lot about, well, about us. What about this socio-demographic and ethnicity and religion factors? Patients from a very low income background reported experiencing poor communication and poor provider satisfaction. A systematic review and meta-analysis of 18 studies, almost 10,000 patients, found that compared with patients with socioeconomic status was not low, those of a low socioeconomic status experienced significantly lower empathy from clinicians. That's the experience of patients. The same was when you compare with all non-white patients with all white patients, but this difference didn't reach significant statistical significance. Regarding religion, there is one study I found, is that in Switzerland, a study of 100 patients with non-affective psychosis. Of them, 16 had psychotic symptoms reflecting aspects of their religious beliefs. Now, of the 100 patients, most had reported that religion was an important aspect of their lives. However, only 1/3 had raised it with their clinicians. And in half of the cases, the clinicians' perceptions of patient religious views was not correct or totally correct. And we don't, as I think someone said, we don't do religion, well, maybe we should. What about the working environment? A survey of 63 physicians found that the stress at work and being overworked had a negative impact on their empathy, with specific comments on time pressure, clinical workload, and time away from direct patient care, especially allocated to paperwork and admin. Specific settings can be particularly difficult. In a study of staff working in inpatient wards in Latin America, staff reported lower levels of empathy compared with people working in the community. A survey of English mental health teams found high emotional exhaustion among acute ward and community mental health team staff and social workers, as well as greater emotional strain related among other factors to a highly demanding job, low autonomy, and limited support from managers and colleagues. So it is possible to, to mention as a possibility that different management styles may affect psychiatrists' ability to deploy empathy in clinical encounters. And more research is needed here. Now, the beliefs about the causes of mental disorders may also be related to the level of empathy toward patients. Basically, this slide, the summary is that the more you believe into a biologically reductionistic explanation for mental ill health, the less likely you are to be empathetic toward patients, and the more likely you are to want them to be away from you, right? That's basically the summary of this slide. And importantly, these findings were sort of correlational. So it was difficult to establish a causal relationship, but there was a study by Day in 2018 that suggested that a causal role of knowledge and training on empathy, because they found that given information about the treatability, service provision, training, and policy went a long way to change attitudes, including empathy, towards people with emotionally stable personality disorder. What about psychiatric training? The UK curriculum for specialist core training in psychiatry mentions empathy twice when talking about clinical psychiatric history, empathy as part of the ability to conduct a good interview and demonstrate respect, responsiveness, and concern for patients. The Silver Guide of the Royal College of Psychiatrists for training, psychiatric training, states that trainees should participate in a valiant group or case-based discussion groups, which in turn would help them to, if they participate regularly, to develop their empathy skills. Now, an in-depth interview with 21 psychiatry trainees in London found that one factor influencing their choice of psychiatry been having had positive role models who were approachable, people-centered, and that trainees had been particularly influenced by consultants who took a personal interest in them and their development. Many respondents valued the opportunity to have more time with patients and the psychosocial aspect of care that are associated with psychiatry, as well as having to develop the skills to establish rapport with psychiatric patients. However, a survey of 359 UK psychiatry trainees found that those considering leaving the training mentioned as reasons spending too much time on paperwork, feeling that clinical priorities took second place to managerial objectives, and not having enough time to see their patients. Study into understanding career choices in psychiatry of 159 trainees found that they said that they enjoyed the following things about psychiatry: meeting fascinating patients with complex and interesting conditions, like having more time to be with them and getting to know them than in other specialties, found their clinical work intellectually comprehensive, holistic, biopsychosocial, whole patient approach. But the challenges they mentioned was lack of resources or under-resourcing, systemic changes and constraints like forms, target culture, long waiting lists, feeling that psychiatrists were held accountable for adverse patient outcomes more than in other specialties, and verbal or physical abuse from patients, they reported of the trainees interviewed. So high stress and workload and burnout found that, a systematic review found that a negative association between burnout and empathy. And in the previous study, 37% of trainees mentioned workload and burnout as challenges. So it can be assumed that a significant proportion of psychiatry trainees, and I would say psychiatrists, consultants, could be finding difficult to be empathic, at least as an hypothesis. A word about Carl Jasper's empathy and psychopathology. We all know that always Carl Jaspers is mentioned in psychiatry, as the, paradigm of empathy, empathic understanding, and there is a quote here. When trying to understand patients' subjective psychopathological phenomena, he writes, we sink ourselves into the psychic situation and understand genetically, by empathy, how one psychic event emerges from the other. So that's empathic understanding leads directly into the psychic connection itself. So that's the traditional, the received view that we all learn and hear about. Importantly, Jasper warns that the immediacy of the psychological connection, it's being self-evident, is not a proof. And we need, as clinicians, we need other sources of information such as personal history, third-party information, etc. It's not just an intuition, right? It needs to be backed by facts. But there's been an interesting conceptual development recently about basically saying that we are not, that we should abandon and give up the concept of empathic understanding developed by Jaspers, because it is not possible to do what it is claimed that we do. And not just that, but it creates a situation of epistemic injustice. Because assuming that the clinician can know the lived experience of the patient risks that we get a wrong representation of the subjective phenomena and risk undermining the patient's epistemic privilege, because the patient is the one who is living what they're living, and they know what they're living, or at least they have first-hand experience of what they're living. And this is important because psychiatric illness is an epistemically transformative experience. The patient is thrust into an unfamiliar life world with new and often ineffable meaning structures. So, whilst phenomenological psychopathology advocates for the patient epistemic agency, because what they say is the core of what we capture and what we use, there is a problem of an epistemic appropriation or epistemic co-opting, with the clinician believing that they have equal subjective knowledge as the patient to those with the requisite lived experience. And this has the risk of error, leading to misdiagnosis, mistreatment, and an overall misunderstanding of the experience at hand, co-opting the epistemic privilege of the person or the patient, the client or the service user, with a degree of intellectual arrogance. Epistemic objectification, treating the patient just as a source of information. So they propose that empathic understanding is fundamentally epistemically flawed, and propose that it should be replaced with virtuous listening. To end up, in a practical notes, 10 easy evidence-based ways to enhance clinical empathy, as reviewed by Jeremy Howick last year. Very simple things that we can do. They're not very time consuming is greet patients in the waiting room instead of having the receptionist on an electronic notice board. Introduce yourself by name. In situations such as home visits, care homes, and I could say work rounds, sit down. Practitioners who sit down are perceived to spend more time with their patients. Look at the patient when talking with them rather than at the computer screen or notes. Use facial expressions and other nonverbal communication that mirror the patients where appropriate to show that you understand and build connection. Don't interrupt the patient. Paradoxically, not interrupting the patient can reduce the overall consultation length whilst providing patients with the opportunity to express their concerns. Go beyond objective observation and deploy curiosity. Be conscious of your body language. Engage in body language such as slight lean forward. Express concern with your tone of voice. Give a truthful, positive message of hope, even if it is just something like, we are going to do our best to take care of you. Positive messages can reduce patient pain. And finally, take care of yourself, because the job we do, we listen today, is stressful and difficult. So there is a lot of research needed on conceptual classifications. We need to do empirical work on whether clinical empathy impacts mental health patients' experience and outcomes in psychiatry. We need to have data on the current real-world practice of clinical empathy in psychiatry in the UK and beyond. We need to understand the factors that promote or prevent clinical empathy in different subspecialties like CAMS, older adults, eating disorders, general adults, etc., etc. And the different professions of mental health care. Mental health nursing, OT, social workers, mental health managers, mental health lawyers, who are an important part of our work. Differences in terms of socioeconomic status, ethnicity, gender, religion, and the context of mental health care, whether this is provided face-to-face, remotely, apps, AI, or when people are detained involuntarily in hospital or are subject in the community treatment orders. And I want to finish with a clinical vignette. This is not a real patient. I invented it, but it will resonate with those of you who are practicing clinicians. And I mentioned this vignette as a way of reminding everybody about the challenges of empathy. I think Rob said a little bit about that earlier. But this is a general adult situation. This has nothing to do with forensic patients. Peter assaulted his father a few hours ago. The police were called and brought him to the A&E under Section 136 of the Mental Health Act. Concerned about him because he was talking to unseen people with extreme poor self-care and very aggressive. Over the last few months, Peter became increasingly isolated in his bedroom alone, not talking to his parents, friends, dismissed from work after an altercation with colleagues, which was unclear what had occurred. He's mute and wants to go home, but finally disclosed that his father is magnetically controlling him, forcing him to plan his own suicide and the killing of his mother and other relatives. Peter said that he doesn't want to do that, but is finding it increasingly difficult to resist and cannot guarantee that he will not do it unless he kills his father, as a way of preventing doing the other things that the father was trying to get him to do. An assessment under the Mental Health Act takes place. He's admitted to hospital, and shortly after being admitted, unprovokedly, he seriously assaults two members of staff. Thank you.